We've made things a little smaller. We've, copied pacemakers. We've done some work, but we're pretty much at this point still. So, you got to know that when you're getting into neuromodulation. But that's because neuromodulation represents an enormous potential that is quite complicated, that matches itself with exactly how our nervous system works. And I would be remiss if I did not mention that there is quite an inflection point in the history of neuromodulation that has to do, at least in the headache and facial pain world, that has to do with anti-CGRP therapy, right? We are in a new era. We know that there are electrophysiologic properties associated with anti-CGRP therapies. We know that it changes what's going on, but most of the studies in neuromodulation are before this era, so they have to be interpreted with caution, as are most of the studies in facial pain. So one of the things to consider is that maybe a lot of these studies would be differently if we used that as part of our selection criteria. But neuromodulation marches on, and for many of you might be familiar with neuromodulation from the cardiac perspective, either pacemakers or defibrillators, but we now have an enormous armamentarium of actually pretty similar devices, but deployed in different ways. For example, deep brain stimulation, which is a significant portion of my practice, is now the standard of care for Parkinson's disease and essential tremor. It works remarkably well for tremor. It is also used for obsessive compulsive disorder, and a new trial, again, is starting for depression. We have vagal nerve stimulators, which I'll talk about later, which are already FDA approved for epilepsy and depression. We have sacral nerve stimulators and spinal cord stimulators and hypoglossal stimulators for sleep apnea. We have tibial nerve stimulators. It goes on and on. But all of these devices are quite similar and use the sort of same platform. And the other thing to consider is that, this is a med tech perspective. And it's important to recognize that this is a lot of money that people are spending on treatments. And sometimes it's necessary, but, these are businesses that are at play here, and they're potentially making a lot of money. So it always, we need to make sure that we understand the conflicts in our community. The other thing is that we have learned over the years that the application of neuromodulation cannot just be applying the same thing to everyone for two reasons. One, the type of neurologic function that you induce with the neurostimulator is different depending on where you are. And that's not very surprising, considering we know the diverse effects of pharmacological therapy all over the body. But it's also true that we now know that neuromodulation cannot just be, started and not optimized for individual patients, because there's a significant amount of individual or intra-person heterogeneity, and we know that we do not get it right. And so now we are learning that a lot of neuromodulation studies have to be done with periods of optimization employed. Now, when most people talk about neuromodulation, they talk about, really the onset of spinal cord stimulation with Shealy and the idea of gate theory. But we already know that gate theory is not how it works. It's just one way to talk about it. The idea being, if you hit your, foot and you rub your leg, then it's all better. But it's not all better, and it's not how it works, and a lot of things are still being figured out. But what we do know is that neuromodulation primarily affects the things that are most responsive to changes in electromagnetic fields, which are large diameter fibers in our body. So A beta, A delta are the things that respond the most. Just stimulating A beta fibers, we wouldn't necessarily imagine that would help give pain relief, but in many people it does. And the way that it does, based on animal work, is probably modulation of a GABA system or second-order effects that are going on here that we see in some people and not others. There's essentially an infinite degree or parameter space of how the stimulation can even occur, right? Just because you put a bunch of electrodes in the body and you have it hooked up to some kind of pulse generator, you now have to make decisions about which electrodes you're stimulating, which are anodic, which are cathodic, whether or not, how you're shaping the field, and then what the waveforms even look like. And the waveforms affect the reach of the neurostimulation. They affect how it's modulating the ganglion cells that are being responded to by the neuromodulation. And there are now hundreds of algorithms for how to do this and where this is going. You can change the amplitude of the stimulation, which we're all familiar with. You can do tonic stimulation. You can do high frequency or low frequency or intermittent. You can interleave the stimulation together. You can do bursting algorithms that are harder to feel. You can do sub-perception algorithms where patients don't feel it at all. There's so many degrees here that basically what we know is that there's a lot that we don't know. And we're just starting to scratch the surface in a systematic way. And then there's where we put these stimulators and what we're using them for and what mode they come in. And this is just a small number of them, but I'll go through them because these are the ones that are specific to or related to orofacial pain or headache. So first we have non-invasive vagal nerve stimulation with the idea that through the skin, we can stimulate the vagus nerve. And for anybody familiar with the vagus nerve or a neck, there is a large muscle, the sternocleidomastoid muscle, that's in the way. And behind the sternocleidomastoid muscle, there's the carotid sheath, and inside the carotid sheath is the vagus nerve, and it usually sits between the jugular vein and the carotid artery. So the assumption is that with a transcutaneous device, you can stimulate the vagus nerve behind this muscle and stimulate it enough that it can actually produce a significant effect. Next, there's vagus nerve stimulation essentially around the ear. As we know, the vagus nerve also innervates the ear, so if you stimulate there, you can get portions of the vagus nerve, and by doing so, look for clinical effects. And sure enough, there are reports that we can get some clinical effects. Then there's external trigeminal nerve stimulation. There's a lot of parts of the trigeminal nerve that are accessible to stimulation. In fact, one of the first uses of a commercial application of neuromodulation in the 20s was electrotreat, where people were using basically a TENS unit to treat pain. It's been around forever, and people have obviously used it on their face. I'm sure your patients have used TENS on their face when they have orofacial pain. Lots of ours attempt to do so, despite the fact that no medical device company wants to deal with the face. There's transcranial magnetic stimulation, and that's where you're inducing a magnetic field strong enough that it can cross through the skull and actually affect the brain, usually focused on depression, but the FDA has approved this for depression, versions of it for OCD, versions of it for smoking cessation. It is now becoming more widely accepted, and it actually has gained traction for insurance approval. So it's one area where there's been sort of a win for neuromodulation, despite there being low to moderate effects actually reported. But the risk-benefit ratio is extreme, with the risks being extremely low. Next is remote neuromodulation, I'll tell you about in a little bit. But this idea is basically to cause noxious stimulation in a different part of the body, and by doing so, you get a conditioned response for the primary pain disorder, and is already FDA approved or FDA cleared. Then for peripheral invasive neuromodulation, we have vagal nerve stimulation, which I'm sure many of you are familiar with that I'll talk about. There's phenopalatine ganglion stimulation. That's come and gone and maybe coming back. There's trigeminal nerve stimulation, which is a part of our practice, occipital nerve stimulation that Dr. Zimmerman talked about. And then I sort of categorize one other category is central stimulation. I'm putting electrodes in the brain, on the brain, around the brain to modulate how the brain works.